right, so I'm Chien. I'm a medical breast oncologist at UCSF and the medical director there. I'm so happy to be here. This is actually my first year at this conference, but it's really nice to actually see some familiar faces. So my goal today is to give you updates in metastatic breast cancer. It's been a really active couple of years for breast cancer, both early stage and metastatic. I had to really think hard at picking and choosing what I'm going to talk about today because there's been so much rapid change and drugs that are being approved, which is really super exciting. So I'm going to, these are my disclosures. I'm going to first talk about practice-changing studies for HER2 positive metastatic breast cancer. The first is the PATINA study, which is using palbociclib, which is a CDK4/6 inhibitor you may have heard of for hormone receptor positive HER2 negative disease. But now we are seeing that there's a role in HER2 positive metastatic disease. We're going to talk about trastuzumab deruxtecan, which is also TDXD. This is a novel antibody drug conjugate that is approved in metastatic, and early stage, metastatic HER2 positive disease. And there's data now showing that it is going to probably change first-line treatment. We'll then move on to hormone receptor positive HER2 negative disease and a new PI3 kinase inhibitor, inavolisib, and then a number of new oral hormone therapies, oral SERDs, I'll mention briefly, and then this idea of tracking circulating tumor DNA. We get a lot of questions about this. Can you use that instead of or in addition to scans? I will be talking about that in the metastatic setting, which is different than a lot of other indications where people are asking about MRD in the early stage setting, using it to identify early recurrence. So that's not the setting I'm going to be discussing today. We'll be talking about using it in the metastatic setting. And then finally, just quickly, a couple new press releases and early presentations for triple negative disease, looking at antibody drug conjugates in the first line space. Okay, so we're going to start with HER2 positive and a case, 47-year-old newly diagnosed with a hormone receptor positive, HER2 positive early breast cancer, clinically node positive. The PET CT up front was negative. So this is an early stage cancer. The patient went on to receive neoadjuvant TCHP chemotherapy with HER2-directed therapy, and then went to surgery and had residual disease, including 1.3 centimeters of disease in the breast. The lymph node was negative. So per standard of care, this patient received 14 cycles of TDM1 in the adjuvant setting, and then unfortunately 2 years later develops abdominal pain and found to have new liver metastases. These were biopsied, ER positive, HER2 positive still. So what do we give this patient in the first line setting with newly diagnosed metastatic breast cancer? The current standard of care as of today is to give a taxane with trastuzumab and pertuzumab. This is from the Cleopatra study that was initially presented back in 2012. This led to the approval of pertuzumab in 2012. And this showed improved overall survival when you give pertuzumab, trastuzumab, these are the HER2 antibodies, along with chemotherapy. Can we improve on this? And I should say, when you add this combination, with pertuzumab, you're adding an additional 6 months of survival. So this is currently the standard of care. At San Antonio last year, which is our big breast cancer meeting, we're about to go there in a couple weeks, but last year, the results of the PATINA study were reported. And this study asked the question, after you get the first line taxane, trastuzumab, pertuzumab, which is the standard of care, what we usually do is we stop after 6 cycles and then we put the patient on just the antibodies because it's hard to do indefinite chemotherapy. So they're just on the antibodies. And if they're hormone receptor positive, we add in the hormone therapy. And patients can stay on that for a long time. This trial said, well, what if we add palbociclib, which is a CDK4/6 inhibitor, that many of you may have heard of for hormone receptor positive HER2 negative disease. That's been landmark change in that space. But in tumors that are HER2 positive, for the last 20 years, we've been so focused on inhibiting HER2 that we haven't spent as much time thinking about the ER part of the ER positive, HER2 positive. So this trial combined palbociclib, which we know is a cell cycle inhibitor. It helps reverse endocrine therapy resistance. There's no reason why that would not also work in HER2 positive disease. And combined the palbociclib with the hormone therapy while giving the trastuzumab and pertuzumab. And this was a phase 3 study. They compared that to just continuing the standard antibodies and hormone therapy alone. What they found was that the time that the disease was controlled was significantly longer if you added the palbociclib to the hormone therapy and antibody therapy. So the time, what we call median progression-free survival, was the amount of median time that the disease was controlled. It was 44 months in the palbo arm and 29 months in the control arm, which was just the hormone therapy and antibody therapy. So highly statistically significant. So this is not yet approved by the FDA. I fully anticipate that this will be. I've already started doing this in my practice in patients who meet these criteria. So far, I've been successful in getting it approved, but I fully anticipate that for HER2 positive, hormone receptor positive, in the first line setting, after you get your chemo and you're on that maintenance portion, that will be adding the palbociclib to the hormone therapy and antibody therapy. Okay, so that came out in San Antonio last year. At ASCO this year, which is June 2025, the Destiny Breast 09 trial was presented, and this trial compared T-DXd, trastuzumab deruxtecan, which is an antibody drug conjugate, I'll tell you what that is shortly, compared to the standard of care, which I just told you was the taxane, trastuzumab, and pertuzumab. Like all companies developing drugs, once you get an approval in the late line setting, which T-DXd did back in 2022 or 2019 even, then they want to move their drug earlier. And the earlier you can give an effective drug, we believe, we hope, will translate into the best long-term benefit and survival benefit. So they said, okay, let's bring this active drug from the late line, which we know is active, to the first line and go head-to-head with the current standard of care. An antibody drug conjugate, this is a whole new class of agents, some of you may be aware, where it is technically a chemo, but what it is it's an antibody that is linked to the chemotherapy. So there's a few components that distinguish one antibody drug conjugate from another. There is the antibody. What is it actually targeting? In this case, it is targeting HER2. I'll talk about a different drug called sacituzumab that targets TROP2. And then there is the payload, the antibody. For T-DXd, it is deruxtecan, which is a topoisomerase 1 inhibitor. And then there is the linker that links the antibody to the payload. And the idea is that this antibody is bringing the payload more directly to the tumor, hopefully reducing the toxicity everywhere else in the body. I will also say there is this other theory of why these drugs are so effective. It may be related to the antibody targeting the tumor, but it may also just be a novel way to deliver chemotherapy, because once you put an antibody on it, the half-life of this agent is much longer than standard chemotherapy. Mm-hmm. And you might just be releasing that chemo slowly over the course of weeks, as opposed to standard chemotherapy, which is in and out of your body usually within 3 to 4 days. So this is still sort of up for debate, but these are highly effective, a new class of drugs. We have a few that are now approved and many more to come. The reason these drugs are extra, effective is that not only is it being taken up by the tumor cell and the chemotherapy gets released in the cell, but then the cell dies and the chemo gets released to all the surrounding tumor cells around the one that was targeted. So there is a bystander effect. And so you have larger scope of tumor cell killing than the standard chemotherapy. In fact, some of you may have heard of TDM1, trastuzumab and tansine. This is a drug that has been approved since, don't remember exactly, but at least a decade.
Well, it says right here. And I'm right, at least a decade, 2013. It was approved in the second-line metastatic breast cancer setting. And now we use it in the post-neoadjuvant setting like the patient case I just described. But you can see the differences between TDXD and TDM1, why TDXD is superior. So the chemo payload is different. The TDM1 is an antimicrotubule similar to Taxol or paclitaxel, and then the TDXD is topoisomerase 1 inhibitor. But the drug to antibody ratio is much higher with TDXD, so you're getting more payload per antibody. The TDM1 does not have a bystander effect like TDXD. So we fully expected, and we later saw that TDXD is superior to TDM1. But going back to this trial, which is DESTINY-Breast09, where we're really looking at first-line treatment, randomizing to TDXD plus pertuzumab versus the taxane trastuzumab pertuzumab. There was a TDXD placebo arm that they have not reported out on. So they really reported out on just those two bottom arms. And again, you see superiority of the TDXD over the standard of care. So the progression-free survival, median progression-free survival, the amount of time the disease is controlled, was 40.7 months versus 26.9 months. So again, highly statistically significant, a difference of over 1 year. The difference here, though, that I want to point out is that in the study design, the TDXD pertuzumab arm, they just continued until progression. It wasn't this induction of 6 cycles like we do with the taxane HP. So there's a lot of questions about, well, what does that do about quality of life? How do we balance that with this additional 1 year? And what about if you just did the THP and then come in with the TDXD later, you might be able to make up that difference. So it's really important to see the survival benefit, which is very immature when they first presented these data, 16% immature. But you can see maybe those curves are separating, and with more time, perhaps we'll see a survival benefit. But the other point to make is that the trial I just showed you, Patina with palbociclib, what if we don't know if this difference is going to be as large in patients who can now also do palbociclib after the taxane trastuzumab pertuzumab. So you're seeing this pattern where there's a lot of trials, big trials, phase 3 trials that are being done that are positive and leading to practice change, but the actual current standard is also changing. And then by the time those phase 3 trials report out, the scenario they studied may not be as relevant or actually the question at hand, right? And this happens all the time. So we end up having to sort of extrapolate from the data to know, okay, what is the benefit now of doing TDXD first line in somebody who got palbociclib during maintenance, right? So, but it's just, this is what happens when the field evolves so rapidly, which is a great thing. So I do also fully expect that TDXD will be approved in the first line setting. It's not yet. Will it be necessary for everybody? I don't know. I think if it's somebody that recurs very quickly after their initial treatment, I would start with TDXD. But if it's somebody who has, 5+ years before a recurrence, I'm not sure. I think I would consider, I think we need to see the survival data. So these data are literally hot off the press. We'll have to see how it plays out. One note about brain mets. Historically, many of our agents have not penetrated into the brain very well. Tucatinib is one drug that is approved where we know that there is CNS penetration. TDXD also shows excellent CNS penetration. So this is a trial called DESTINY-Breast12, which is a single-arm trial. It wasn't really comparing to anything, but it is just looking at the efficacy of this drug for brain mets specifically. And you can see this waterfall plot on the top, and what it is showing you is the percent decrease in the size of brain mets. And anything that is negative is a response. And rarely do you see a waterfall plot like this where it is almost all response. The ones that are up here that are going up are progressing, but they reported out a response rate of 71%, all comers, They even included patients with active brain mets, so untreated, who hadn't had radiation or gamma knife, having 62% response. So we know that there is really good penetration of this drug into the brain. What we call progression-free survival was at 12 months, 62% had not progressed in the brain. So really, really exciting to have more options for brain mets, specifically for HER2 positive. And that brings up the question of, well, should we be screening for brain mets, doing MRIs? Historically, we haven't been doing that unless patients are having symptoms. Now that we have drugs that can penetrate into the CNS, and we also know that if you do need gamma knife, it's always good to do it when the lesion is a little bit smaller than bigger, because you can increase the risk of radiation necrosis with larger lesions. So I personally have been doing annual brain MRIs for screening in my HER2 positive metastatic patients. So this is sort of the roadmap that we often show, how we think about metastatic HER2 positive disease. I won't go through the details of it, but I'll just say that in this first line, where it historically has been the taxane, trastuzumab, pertuzumab, now here I've just added a box on the right. Could we start with T-DXd? What about adding palbociclib maintenance therapy for hormone receptor positive, HER2 positive? Okay, so we're moving on to hormone receptor positive, HER2 negative disease. Let's start with another case. So 53-year-old woman with a history of stage 3 hormone receptor positive HER2 negative breast cancer. She received neoadjuvant AC Taxol, had a mastectomy, and had significant residual disease, 5 centimeters, and a positive sentinel lymph node. She was started on adjuvant aromatase inhibitor. This was the time before the approval of adjuvant CDK4/6 inhibitors. 4 years later, she develops bone pain, and the PET-CT shows no new bone metastases and a liver lesion. The liver is biopsied, shows recurrent adenocarcinoma, hormone receptor still positive, HER2 negative, and we always send for molecular profiling, and she's found to have a PIK3CA mutation. A PIK3CA mutation is found in about 40% of hormone receptor positive HER2 negative tumors, and it's actually a mutation that we call conserved. So it's not like some mutations like ESR1, where it is acquired over time. With more treatment, more endocrine therapy, the tumor evolves to become resistant to it. PIK3CA mutations, usually you have it or you don't have it. We know that CDK4/6 inhibitors have transformed the prognosis of hormone receptor positive HER2 negative metastatic disease. There are 3 on the market: palbociclib, ribociclib, abemaciclib. They've all been tested in phase 3 trials. From a sort of progression-free survival standpoint, that time until first progression, equivalent. If you look across these 3 agents in their phase 3 trials, they are almost identical in terms of doubling the amount of time that you can control the disease with the addition of the CDK4/6 inhibitors. Where there's some difference is where overall survival has been found. So I'll just say that ribociclib is the only one that has shown survival benefit that was statistically significant. That difference was over a year. The abemaciclib trial, Monarch 3, also showed over a year benefit in overall survival, but unfortunately didn't cross that predefined statistical threshold to be significant. Personally, I think it's equivalent. I don't really have an issue if we wanted to start with abemaciclib. Palbociclib, unfortunately, did not show survival benefit. It's not clear if it's really a difference in the drug or study design. We know from real-world studies that palbociclib does show survival benefit, so it could just be a study design issue. But for this reason, I generally start with ribociclib because that's where we have the data. Abemaciclib can cause more diarrhea, so many patients prefer the ribo anyways. But if there's a reason I would need to switch to abema, I have no problem with that. I would say palbociclib I also will use if we can't do the other 2. I think it is an effective, highly effective drug. So that is the first line. When patients get newly diagnosed, you start with hormone therapy plus a CDK4/6 inhibitor. The question is, well, what about patients with PIK3CA mutations that develop their recurrence relatively early, within the first 5 years, when you're still taking your adjuvant endocrine therapy? So that they're saying, the tumor is saying, I'm already resistant to the hormone therapy. So the Anava 120 trial
randomized these sort of higher risk, more aggressive patients that had early recurrence, PIK3CA mutation, developed their recurrence either on their adjuvant AI or within a year of coming off their adjuvant AI, and randomize these patients to a triplet therapy, which sounds aggressive, right? You're doing fulvestrant, which is the hormone therapy. You're doing palbociclib, which is the CDK4/6 inhibitor, and then inavolisib, which is a novel PI3 kinase inhibitor. They're comparing that to the standard of care, which is the hormone therapy and the CDK4/6 inhibitor. They again found, they found improved progression-free survival and overall survival when you add this triplet, you add the inavolisib to this combination and give a triplet therapy in this population that has more aggressive, more resistant disease. This has led to the approval of inavolisib in this setting. This was approved in October of 2024, and this is something that I do now incorporate in my practice for the right population. What happens, so that's first line. So first line, hormone therapy, CDK4/6 inhibitor. If you have a PI3 kinase, you have an early recurrence, then we'll add in the inavolisib, right? What about second line? And this is where it's like, I won't say the wild, wild west, but it's really complicated. It is a very competitive space. And I would say if I should high level just simplify it, what we do at this point is we need to profile the tumor, looking for mutations that are specifically targetable. And there is no one size fits all. Depending on your mutation, you may be eligible for one targeted therapy and not another. We try to combine a hormone therapy backbone that the patient hasn't seen yet with the targeted therapy of choice. There are some patients that have no targetable mutations, and so there's other options for that. And then we try to run through as many endocrine options as we can before moving on to chemotherapy. I just want to touch on, and there's so much activity in this space, and I just want to mention the work that's going on in terms of novel endocrine therapies. We all know that aromatase inhibitors are really difficult to tolerate. A lot of joint aches, dryness, fatigue. And if you can't tolerate it, you're not going to want to take it. And this is true not just in the metastatic setting, but in the early stage setting especially. There's a new class of agents called oral SERDs. So SERD stands for selective estrogen receptor degrader. And these are particularly effective in tumors that have developed ESR1 mutation. Remember, I told you that tumors with longer exposure to aromatase inhibitors, they're trying to mutate and evolve and become smarter than you and develop this ESR1 mutation that can signal and send signals to the cell to divide and metastasize and be aggressive, and they don't even need the estrogen. So what these SERDs do is they just come in and they just tell the cell to degrade the receptor. So even though that receptor can signal without estrogen, we're just going to degrade it and bypass that resistance mechanism. There are many of these in development, highly competitive space. There are two that are FDA approved, elacestrant and imlunestrant. Elacestrant was approved in January of 2023. Imlunestrant was literally just approved not even 2 months ago in September. These are approved in patients with an ESR1 mutation only, and patients must have had at least one line of hormone therapy, so really the second line and beyond. So super exciting. Giredestrant, camizestrant are also oral SERDs that are in active development. There was just a press release that giredestrant showed improvement in the early stage setting and the adjuvant setting. We haven't seen the data yet, but this would be huge for all of the early stage patients on AI who are really struggling, because these drugs in general are tolerated really well, in my opinion, better than the aromatase inhibitors. Some of them have GI tox, but none of that joint aches and stiffness that really torture many patients. I won't really go into the other novel endocrine therapies. They're listed here. There are many in the highly competitive space. So the EMERALD trial just is the one that led to the approval of elacestrant, where they compared elacestrant to the standard hormone therapy in the second line setting, like fulvestrant. And what they found is if you look at all patients, the difference was very small. It was less than a year. And I also want to point out, look at how these two curves, they just drop
precipitously at the 2-month mark. What that's telling us is that there is a cohort of patients, upwards of 40% of patients, that aren't responding to hormone therapy at all because on their first scan, we're already seeing progression. Those patients are highly resistant, and we're looking at other options. Either maybe those patients should move on to chemotherapy earlier, right? So it's important to kind of look at these data separate from that population, which probably will not respond to endocrine therapy. What we really want to look at is whether or not elacestrant is better than the standard fulvestrant in an more endocrine sensitive population. And that's where you start to see differences later. You kind of selected out the patients who are not responsive to hormone therapy, and then over time you see how those curves separate. What's important is that when you look at patients who have the ESR1 mutation, these are resistant patients, more resistant patients, that's where you see a bigger difference. And that difference was only about 3 months, still more than patients who don't have the mutation. But then we went back to see, okay, if you look at patients based on how long they stayed on the CDK4/6 inhibitor, which tends to be a marker of how endocrine sensitive you are, there are patients who can stay on a CDK4/6 inhibitor for many years. And if you did stay on a CDK4/6 inhibitor for more than a year, you actually benefited more from elacestrant. That difference between elacestrant and fulvestrant was almost 7 months. So it's an example, don't focus too much on the numbers, but it's an example how if you find the right patient population, you can see bigger differences. And that's so key to where we're going with drug development, is to narrow in on specific populations, because you might see bigger results in one than other. Otherwise, you would just discard the drug if you were to just look at the intent to treat population up here in the top, which showed, margin, like a month difference, right? So it's just a reminder, and it's great that these trials are so specific. It can feel challenging when you're trying to get on a trial, but there's a reason, because we're looking for signals in small populations. I'll just quickly show you the data for imlunestrant, similarly comparing it to standard of care, similar to the elacestrant trial. If you look at the wild type, so patients that don't have the mutation, no difference between imlunestrant and standard of care. But if you select out patients with the mutant ESR1, you start to see about 2-month difference. Doesn't seem like a lot, but it is statistically significant. I suspect when they go back and analyze these data and look at how long they were on the CDK4/6 inhibitor, we're going to further see bigger differences. Okay. We've talked about first-line therapy, we've talked about second-line therapy. Now let's talk about the ctDNA. This was the SERENA-6 study. This was a plenary presentation at ASCO this year. And it really is a potential paradigm shift. For the metastatic patients, you know that we measure response or growth based on CT scans. That is the gold standard. The question is, could you use ctDNA to identify patients who develop this ESR1 mutation, right? These are patients who are on first-line hormone therapy, like AI, plus a CDK4/6 inhibitor. If you check their blood periodically, looking for an ESR1 mutation, where I just told you, if you develop an ESR1 mutation, you are resistant to an AI. If you find one, what if you then just switch to an oral SERD, in this case camizestrant? You continue the CDK4/6, or you just stay the course like you otherwise would based on current standard practice until your scan, and you wouldn't switch until your scan shows something. So it's asking the question, can you get ahead of it by making a treatment change before a scan changes? Okay. They screened over 3,000 patients, and they would screen basically around each scan time point, every 2 to 3 months. In those 3,000 patients, they found that 548 had ESR1 mutations. They randomized 315. And what they found was that if you switch to the camizestrant, the oral SERD, at the time of the ESR1 mutation was found, that your progression-free survival, meaning the time until you see a true progression on a scan was longer than if you stayed on the AI until, and do scans and then find the time of progression. So the median PFS with that ctDNA approach, switching to camizestrant, was 16 months before you see progression on a scan versus 9.2 months. So a difference of about 7 months. So this was the big headline. However, I will say that this is not the end of the story, because what really matters is it actually improving survival, right? What we need to see is that we have options down the road, right? Could it be that if you make a switch too early, you're breeding more resistance earlier? And then at the time of next progression, you need to bring in another drug, and then maybe another drug. You're just going to bring in these drugs earlier than you otherwise would. We need to make sure that we are improving the long-term outcome, not just that first progression-free survival. And so many patients ask about this. In my mind, ctDNA is useful in the metastatic setting to find these mutations. But I don't think right now, based on the data that we currently have, that we should be making any switch until we have more long-term follow-up. Okay, so quickly let's move on to triple-negative disease, and then we'll take questions. Triple-negative metastatic disease, historically, there was not clear is there a roadmap. You could do any number of things. Until the Keynote 355 study, where we know that some patients will benefit from immunotherapy, about 40 to 50%. Now the standard first line at the time of initial triple-negative metastatic diagnosis, we test all tumors for PD-L1. If your tumor is PD-L1 positive, the standard of care at the moment is standard chemotherapy like paclitaxel, nab-paclitaxel, gemcitabine carboplatin, with pembrolizumab, the immunotherapy. If you are PD-L1 negative, you just get standard chemotherapy. Second line, we know that the antibody-drug conjugate sacituzumab has been shown to be better than other standard chemotherapies. We also know that T-DXd, trastuzumab deruxtecan, which I told you is approved and highly effective for HER2-positive disease. I won't go into this today, but we know that it's also very effective for HER2-low disease. A subset of triple negative are HER2 low. HER2 low isn't a new subtype. What it is a cohort, a subset of HER2 negative. You have some HER2 expression. It's not enough to be positive, but it's not HER2 zero. And those patients also benefit from T-DXd. And then PARP inhibitors if you have a BRCA mutation. The ASCENTO-4 trial was just presented at ASCO this year, challenging the first line current standard of care of chemo plus pembrolizumab in patients with PD-L1 positive metastatic triple negative breast cancer. They randomized patients in the first line to either sacituzumab and pembrolizumab or chemo and pembrolizumab. And what they found was that the progression-free survival was significantly longer, 11.2 months versus 7.8 months, so about 4-month difference. The overall survival is not mature. This is not yet approved, though I suspect it will be. They also presented ASCENTO-3 at ESMO this year, which is in October in Berlin, looking at the PD-L1 negative cohort. Again, challenging the standard first line, which is chemotherapy. So these are PD-L1 negative patients with metastatic triple negative, newly diagnosed, randomized to either standard chemo or sacituzumab. TROPION-Breast02 took a similar first-line triple-negative population, and they're testing their antibody-drug conjugate, datopotamab deruxtecan, versus standard chemotherapy. Both of these trials were positive trials. So sacituzumab is better than standard chemotherapy in terms of progression-free survival. Datopotamab is better than standard chemotherapy in terms of progression-free survival and overall survival. So in every trial that we have done comparing antibody-drug conjugate to standard chemotherapy, the antibody-drug conjugate has won. So really exciting. The sacituzumab uses an antibody against TROP2, which is highly expressed in all breast cancer, I think 70 to 80% or 90% in triple negative. And it's linked to a drug called SN38, which is a derivative of irinotecan, another topoisomerase 1 inhibitor. How are we going to decide, assuming both drugs get approved in the first line setting, which one to go with? And this is where, this is also highly competitive space. Personally, I think it's going to come down to side effect profiles and other patient, individual factors. So things to consider for sacituzumab, it's given 2 weeks on, 1 week off. The main side effect is that it drops blood counts significantly. We have to start patients with growth factor support with cycle 1, day 1. We just know those counts are going to drop. Nausea and hair loss is seen more. Datopotamab is given only once every 3 weeks, so a little bit more convenient. Both are IV. The main side effect there, you can get some dry eyes, red eyes, mucositis, so sores in the mouth, sensitivity in the mouth, also some nausea. You can see some hair loss, but a little bit less from what we've seen so far. So super exciting that we have new drugs being approved, hopefully being approved for triple negative disease, beating chemotherapy. So in terms of revising this roadmap that I just showed you, I just sort of added, it's possible we're going to come in with sacituzumab into the first line, datopotamab also possibly going into the first line. So these roadmaps are, we make these slides and we've got to edit them and make new slides because it's changing so fast. So this is my last slide. I want to leave you with the idea that the future is extremely bright. The pace of drug approval is accelerating faster than ever. The effective drugs are moving quickly from the late line setting into the first line metastatic setting and now into the early stage setting. We just saw presentations for trastuzumab deruxtecan in neoadjuvant space and post-neoadjuvant space. So it's going to be a total, not mess, but we're not going to know what to do if we're going to now use it in early stage, and then what do we do in the metastatic setting, rapidly evolving. Trials are being conducted in more specific targeted populations. That is a good thing for us to find signals. We're also developing novel methods for monitoring disease progression that may help us improve outcomes as well. So with that, I will end, and thank you so much for your attention.
I'm very surprised to see that fulvestrant came in 2002. Are we at any space going to be able to stop those shots?
Oh, I think so.
You do?
So oral SERD, so fulvestrant is a SERD, right? It is a receptor degrader, but for those that don't know, it is delivered intramuscularly. You have to get 1 injection in each butt cheek every month. And it can cause pain and nodules, and oral SERDs are doing the same. We believe the pharmacokinetics, the bioavailability is better than the intramuscular. So we have already approved 2, but those currently are in the mutant population only. But
what does that mean?
so the ESR1
Oh, I see, mutation.
Yeah. So right now, if you have an ESR1 mutation, I will prescribe that instead of fulvestrant. Now the thing is though, if you kind of go down the roadmap, you see that with each line of therapy, ideally we are changing both the endocrine therapy and the targeted therapy. So yes, we could do AI and then an oral SERD, although the oral SERDs are going after the first line space right now. But it all gets reshuffled, and at some point it might be that if you've already received an oral SERD in the first line, and maybe in the second line, at some point we might, okay, well let's try fulvestrant. That's sort of how it works. We want to kind of keep that hormone therapy, but we don't want to keep using the same one.
So I had a question about funding for future research and clinical trials. Are you seeing an impact with all the changes with the government funding, or do you think that future will continue to look bright despite all of that?
I do think it will continue to be bright. For better or worse, a lot of these trials are funded by pharma, so that has been unaffected. But we are seeing cuts in other ways, but I personally don't think we're going to see that play out in a way that will impact patient and drug development.
But at UCSF, with all the doctors they have, do you guys talk about when to move on to that next drug, or is it just individual doctors?
You mean, for patients?
Yeah,
For individual patient cases?
right, I mean, is this with all of you, because you're a group and I know you must meet, so do you guys kind of decide this is the drug that UCSF is really looking into, or how does that work?
Oh, for trial. When we look at our trial portfolio, we sometimes will have two drugs that are really going after the same space. We're not at all kind of biased by companies and such. So we really look at what are the needs of our patients, where are the holes in our portfolio, right? We may have a lot of first line trials, but no late line trials. And we may have, a lot of these trials, it's like they have cohorts that open and close and then there's no spots. So sometimes having more than one is good to have options for our patients.
Thank you.
So as to follow on to the fulvestrant, so the approved two drugs, were they given orally or
Both are
IV?
oral.
Oh, wow.
They're oral.
Okay.
That's-
Quick question. I think you said the final sentence that you're looking at ways of detecting metastases. That's what I think you said. New ways.
With the blood tumor DNA.
Yes, I don't know. So currently, my oncologist, for instance, I mean, there are methods of care different from United States compared to Europe. So in Europe, you test like crazy. You do imaging like crazy, CAT scans, top to bottom, and everything. My oncologist doesn't believe in that. I heard another oncologist does it differently. So, do you recommend CAT scans with substance? I mean, to detect the metastases because they can be there, right?
So for patients with metastatic disease,
No.
okay, so
Before.
that's different. So if in the early stage setting, currently it is not part of the guidelines to do scans unless the patient is having symptoms.
Okay, so
But
you're waiting
this-
for pain, right?
Well, okay, so this is a whole nother topic of using ctDNA to detect early recurrence. It is controversial. I think that I'm hearing from you that waiting for pain to detect, metastasis is not satisfactory, and I completely agree with you. I think this is a huge unmet need, is to find better tools to identify recurrence before you have symptoms and even before you see it on a CT scan. The hope is that if you detect it early enough, that you might still be able to eradicate it and still cure the patient and actually change the long-term outcome. But that's the piece that we need to prove, is that if you intervene, that you can actually change the outcome. We haven't shown that piece yet. We have shown that if we do find the ctDNA, there's a strong correlation that you are at high risk of developing a recurrence. So there is what we call prognostic. But what we haven't shown is what to do about it. If you intervene, we could be just exposing you to more toxicity earlier. We could be breeding more resistance earlier. We don't know that we are improving survival. So it's a tough thing because I also believe it's in general good to identify things earlier. It's the intervention piece that is the question mark right now.
So that would be CT plus DNA from the blood?
CT stands for circulating tumor DNA, not.
Oh, from the blood, so it's just
Yes,
the blood.
from the
Okay,
blood.
ctDNA.
But in my mind, if you find something on the ctDNA, the one thing I would intervene on is to get a scan, just to see if you have metastatic disease. The problem is then, okay, well then how frequently do you follow the ctDNA? How frequently do you do those scans? These are all outstanding.
Thank you so much.
Yeah.
I came a little late, so I think I'm behind the curve of the worst. First of all, I'm delighted to hear that things are happening so quickly. My wife has metastatic breast cancer, and my basic question relates to, I think, what you said before, which is 5 years ago she had a diagnosis. She had chemotherapy. Now she's every 3 weeks on an infusion. She's had brain metastases. And the question is this, so overall, she's been on the same infusion for 4 years. Things have been working fine. Are you saying that there are new medications coming out now? And the question is, do you start a new medication that will be helpful with the current one if it seems to be effective, or should you really wait? I was trying to figure that out.
So
Wait, if something looks good.
if something is working well, as long as it has, especially 4 years, I mean, it is working well,
Right.
don't rock the boat, stay on that. If and when things start to wake up and progress, there are many options available, but I would not change
You
anything.
don't change it, even the new ones.
Yeah, I mean, this is the caveat that I don't know details of individual cases, and I promise never not to like talk about individual cases, but as a general principle, we stay on things as long as they're working. Yeah.
Would it be an exception in the case of brain metastases and the blood-brain barrier? If she's had some of these, if she continues with that, is that a sign you might want to trade for this other medication that seems positive for that?
Similarly, if things are stable, whether it's the brain or outside the brain, I would stay the course.
All right, thank you
Yeah.
very much.
One last question, Helen, you had.
Can you comment on vaccine trials?
I will just say that there are vaccine trials, many across the country. We will have one opening at UCSF in probably the next 3 months. So far, we have demonstrated that we can evoke an immune response from patients. That has been proven many times by many trials. Whether we're able to see a true anti-tumor response in a patient that that is better than others, we haven't seen that yet, but there are many active programs for all the subtypes.
Is that trial gonna be for metastatic? Sorry.
Yes, it is. It's
Yeah.
for metastatic disease. It is in all subtypes,
Wow.
triple negative, HR positive, and HER2 positive.
What is it called?
I just want to say thank you. Just a comment. I just want to say thank you. First of all, great presentation. Lots of detail, more than, I'm sorry, half of that was like right over my head. But I want to say that as a metastatic breast cancer patient, like I don't think I've ever actually seen Sheila, this is first line, second line, and possible what's the next step. And so I appreciate like actually the because my doctor, who's fantabulous, I love her so much. She's like, there's plenty of options for you. Don't worry. And I'm like, okay, I'm not worrying, but I'm like, but in the back of my head, I'm like, what are those? And so I think, one, thank you, but then two, I wonder, as a person who just kind of is, I'm pretty good at doing my homework. Like, where do you find out what the first line, second line processes are?
Yeah,
Like, is the best way to ask your doctor? Because like, I think she just doesn't want to worry me. She's like, you're good. You know. Do you know what I mean?
So the options, if I were to give this talk in 3 months, I'd probably have to like change it all, right? So the options are constantly changing.
Yeah.
If you wanted to go to like a site where they will list what's approved, it's the NCCN guidelines. But I would say those aren't even the most up to date based on approvals, recent press releases, and while what I presented, some are not even approved yet. It's really to give you a flavor of all the excitement that's happening,
Yeah.
but it's rapidly evolving. But if you wanted a kind of more objective place to have the different lines, it's the NCCN guidelines.
So if you have a doctor, because I'm also at UCSF, and let's say I want to be in that trial, do I just tell Dr. Morisco that this is something that I learned about from Dr. Chien?
Yes, so she, it's not open yet, but again, we wouldn't want to put you on until one needs it, right? So things are going well, stay the course. Yeah.
Even for the vaccine, you wouldn't do that until you had some
Yeah,
progression.
it's a therapeutic vaccine trial, so it's to treat the active cancer.
Then don't tell them.
All right, thank you so much.
Thank you.
Thank you.